Good, good morning. Okay, let's get this all set up. All right, everyone, good morning. So, this is our last arrhythmia agent, antiarrhythmic agent talk. We're up to calcium channel blockers, which are the class 4 agents. And the two most important ones of these are verapamil and diltiazem. Both of these agents work to obviously slow calcium channel cells of the SA and AV node. They depress automaticity, decrease conduction velocity, and increase refractoriness in the AV node and the SA node. And for this reason, they are particularly good for treating AV reciprocating tachycardias involving the AV node, such as orthodromic reentrant tachycardia. And you can see on the action potential all of the various. Uh, uh, Hold on a moment. I'm so sorry. The action potential, we see that where it affects, which is phase two of the action potential, and it generally has a very small impact on the action potential. And, historically, it might be of interest to some to know that, adenosine, which we now routinely use to block the AV node and terminate most forms of, or the most common forms of SVT, such as ORT or AVNRT, has only really been around since about late 1980s, early 1990s. And prior to that, pretty much everybody got verapamil, who was like beyond a year or two of age, to terminate SVT, and it would be given as an IV push. Typically, push is a little overstated because it causes hypotension, but it would be given over a couple of minutes, and then oftentimes, 5 to 10 or 15 minutes later, it would work. So it used to be used quite a bit more commonly. Importantly, these agents don't have any direct EP effect on atrial or ventricular myocardium, except that slow channels may be important to myocardial early after depolarization, which may play a role in some forms of arrhythmias, such as Bell-Hassan's tachycardia, which you remember is a form of LV outflow tachycardia, and it may explain why calcium channel blockade can be helpful in treating patients with LV outflow VT. Both of these agents are well absorbed from the gut, but are only 30 to 40% bioavailable after the first pass metabolism. And very little is left when it's excreted in the urine. And the elimination half-life of verapamil is between 5 and 12 hours, and diltiazem's half-life is about 3.5 hours. And both of them can be given IV, but it's very important to remember that verapamil can be very hemodynamically embarrassing, much more so than diltiazem. And one of the reasons that we don't use it as much as we used to is because of this fact. It typically comes fairly concentrated, and so you have to be very, very careful when administering it. So again, hypotension is one of the most important side effects of these agents, but particularly with verapamil. And so usually what we'll do is dilute it with a lot of saline, try to give it slowly, but almost always causes some degree of hypotension. It can depress myocardial function. When they're given chronically, calcium channel blockade can cause constipation. That's probably the most common routine complication of these agents. It can cause dizziness, nausea, or headache. And then, of course, because of their impact on AV conduction, they can cause AV block. But this is almost exclusively seen in people who already have AV block. So, as a general rule, you wouldn't want to use this type of an agent in somebody who had pre-existing heart block or maybe significant first or second degree heart block, it could exacerbate it. But for patients who have normal AV conduction, it's generally safe vis-a-vis the AV node. In terms of drug interactions, it can increase cyclosporin levels, which of course is an agent we rarely use today, theophylline levels, and carbamazepine. Diltiazem does pretty much the same thing, can also increase digoxin levels. Um, Now, very, very importantly, and we've talked about this, the use of these agents in people with WPW is contraindicated because it may enhance accessory pathway conduction, thus enhancing the possibility of rapidly conducted AFib and life-threatening VFib. This is the same reason why digoxin is contraindicated in patients with WPW. And now, it can be used in patients with WPW to acutely terminate SVT, ORT. In the present era, you don't see it used very often because we have other agents to do that. The most notable one, obviously, being adenosine. However, you should be aware that verapamil is not unreasonable to treat an acute episode of SVT, particularly if you have nothing else. But in 2024, that would be unusual. Okay, so verapamil is in IV form is given as 0.2 to 0.1 milligram. I'm sorry, 0.1 to 0.2 milligram per kilo IV over 5 minutes. And quite frankly, I would recommend giving it even slower. You can repeat it in 30 minutes, and importantly, it's generally not recommended in children who are less than 2 years of age. And that is because when verapamil was used more commonly, largely in the era that preceded adenosine's introduction, it was demonstrated in a number of papers in the early 1980s that verapamil caused cardiovascular collapse in a good amount of newborns and small babies who received verapamil. Now, in retrospect, probably the reason that happened was at least in part because the dose was given too rapidly. Again, it comes fairly concentrated, and unless you're very, very careful about diluting it adequately so that it can be given slowly enough, it's very, very easy to cause hemodynamic embarrassment with verapamil. However, even though I've explained to you that probably it's safe if it were given slow enough, the numbers of papers that came in the early 80s were significant enough, and the development of other agents for the acute management of tachycardias are large enough that in 2024 it would be considered a bad idea and something we would not recommend in infants less than, say, 2 years of age. So really should avoid the use of verapamil in that age range, pretty much, I would say universally. The maximum dose in any size human is about 5 milligrams per dose. And then for oral dosing, verapamil can be between 4 and 8 milligrams per kilogram per day, divided Q8. It does come for adults in a longer acting variety, but the typical dose is 4 to 8 per kilo. Now, diltiazem is used pretty much in pediatrics exclusively for its effects on the AV node. It's a very good AV nodal slower, particularly in the setting of primary atrial arrhythmias, like a patient who comes in either AFib, for which it's probably the most commonly used in the adult world, but in our world, probably more commonly for people, say, in ectopic atrial tachycardia, where you need to get rapid ventricular rate control. So the typical dose is 0.25 milligrams per kilogram IV over 5 minutes. And again, I have used it a fair bit, and I would recommend again that it be given a little slower, maybe over 10 or 15 minutes. But diltiazem, usually, if given slowly, is not as hemodynamically embarrassing. And we, in fact, wrote the first paper on the use of this back in 2000. We had maybe 8 or 10 patients in whom we used it, and we actually used it in one or two of the patients were under a year of age. So I think probably at least 8 months and onward, it's probably safe. Could be safe younger, I don't know, but I believe the youngest patient in our study was about 8 months old. And the infusion rate is 0.05 to 0.15 milligrams per kilogram per hour. That's the infusion rate that diltiazem should be written for. Typically, what you'll do is give a dose, see what effect you have. If you have minimal effect, you can usually give another dose, maybe 10 or 15 minutes later, and you can start at 0.05 mg per kg per hour and just dial it up as you need it. And the agent is generally fairly safe. But again, the younger the baby, the less comfortable we would be. Probably anyone under 6 months, I would sooner use something like Esmolol to block the AV node if that were necessary. All right, any questions about any of this? All right, I guess not. I don't know if that's a good or a bad sign. So that's it for drugs. So going forward, we'll do different topics and also, of course, unknowns, such as the next one. So this is a 15-year-old male with a history of feeling tired and being weak. And this is the patient's electrocardiogram. So why don't we ask Vlad what he thinks is going on in this tracing?
Good morning.
Hi, Vlad.
So this is a 15-year-old. First thing that sticks out is that this is a bradycardia. Looks like the rate is about 60. Um, Next question is whether or not it's sinus. Looking at it, there's a very prolonged PR interval.
Mhm.
But the P waves do look like it's likely sinus, like the axis of the P waves. And it looks like there's always a P prior to every QRS and vice versa. And looks like the PR interval is relatively the same, so probably a first degree heart block.
Right. So that's exactly right. Excellent, Vlad. So if you were going to describe this, you would say the patient is in sinus rhythm with first degree heart block. And in this case, I would also comment on how long the PR interval is, because, of course, some people have first degree heart block with a PR of 201 milliseconds, and other patients like this have a PR that exceeds 400 milliseconds. Um, Okay, so this patient comes in your office, and this is the very first time you've ever met this patient. So, what would you do, Vlad, to evaluate this patient?
I'd be curious to see if he's able to mount higher heart rate with activity.
Okay, so
And
you
then,
actually go into the hallway, into the stairwell, and you walk him up one flight of stairs, and he gets his heart rate up to 100 just from climbing one flight of stairs. Robin Berry screams at you for doing that, but if you do that, and the patient seems to be able to conduct in your poor man's test, but how could you better assess that?
we can better assess his heart rate response. You can always
Yeah, like conduction in general.
um, want to, I think, I want to get an EKG while his heart rate is faster. So I don't know if it'd be helpful to get it while his heart rate's at that 100, or if you can pace him somehow, or maybe like outpatient monitoring
Well, how could you do this non-invasively?
non-invasively, maybe
Yeah. Well, you're
like a
saying I
Holter
could
or a
pace
Zio.
him. You're saying I could pace him. So I don't, before we bring him into the cath lab and instrument his heart, which is, of course, dear to my heart, but probably not in the best interest of this patient. Um, what would what could we do? I think you said it, but
Like a, yeah, like a Zio patch or a Holter monitor for to
yeah,
see what happens in his
right.
regular day-to-day life.
So you certainly could do like a 24-hour Zio patch or even an old school Holter monitor or any kind of ambulatory ECG. Okay. What else what do you think could be the differential diagnosis of this? What is the most common cause of this?
Yeah, like in a 15-year-old in this area is line is what I typically think of if it's like an acquired. um, heart block,
Well, it
or I
usually,
guess not even heart block, but
well, it's a form of heart block. It's first degree heart block. I mean, the first thing to say is the most common cause is idiopathic. We actually don't usually know in most people. That's a bit of a trick question. But yes, acquired causes are the things we worry about. So yeah, Lyme carditis could be one cause. What other things could cause first degree heart block?
uh, you'd want to send some TFTs, look at his thyroid.
Right? Hypothyroidism can definitely do this. I always tell the story that I once had a patient with hypoplastic left heart syndrome who had congenital hypothyroidism. And when she was a teenager, her mom allowed her to start giving her own meds to herself. And one day she came into the office at about 15. She was a Fontan, and her PR was just like this. And I got all crazy and I sent all sorts of labs and had, did other testing. And when about an hour after they left the office, I got a phone call from the road that the young lady had admitted to her mother in the car that she hadn't been taking her thyroid medication. So, okay, so hypothyroidism, yes. Lyme disease, yes. Any other common causes?
Think of like in younger babies and younger patients such as babies, I think of like the maternal antibodies that get passed through for neonatal lupus, but this kid's 15, so
Right, so
less likely.
neonatal lupus or Sjogren's is a possibility. I mean, we don't normally do ECGs in children, right? Unless there's some indication. So it's conceivable that this could be a residua of something, and that he's been walking around his entire life with first degree heart block. So one would want to take a good history of the mother, and if the lab work you've just described was negative, I would probably get at least a lupus antibody on the mother because it is not uncommon that the first diagnosis of lupus in a woman is by identification of heart block in their offspring. So that would be something to do. Often turns out to be negative, thankfully for the mother. Any other disorders could cause tiredness, weakness, and first degree heart block? You've got most of them, so you will give you 100% grade on this, but there is one other thing you might want to think about. Was there any other kind of testing you might want to do in this patient? You've already ordered a Holter or a Zio. You've done a fair bit of blood work. Any other blood tests you want to add or any other testing? When you're a cardiologist, you haven't ordered one of the more common tests that we do.
Um, or like an echo.
Well, okay, yes, that was the test I was thinking about. But why would an echo be useful? I mean, I know it's our reflex as cardiologists. We always order echoes in everybody, but why might an echo be useful in this case? What other disease could this be a reflection of on the ECG? Of course, Lyme carditis can cause dysfunction, so that would be one reason too. But are there other things that could cause dysfunction in someone's heart?
Something like a myocarditis or like a fibrotic infiltrative process.
Yeah, I mean, myocarditis for sure could cause this. I mean, you would think the patient would be tachycardic, not bradycardic. You would think that the patient would have other symptoms like fever or other things. But yeah, you would probably want to look at the function to see if there's possibly an acute disease going on. And you would also want to, uh, you know, get a sed rate or a CRP to look for generalized inflammation on the blood work. It turns out in this particular patient, this patient was known to be actually was born and a couple of months of life was diagnosed with actually Mobitz 1 block. And and then actually had some Mobitz 2, and a pacemaker was placed in this patient. And the lead broke about 2 years after it was inserted. And when the patient was then seen in follow-up, it was determined that they were conducting one-to-one with a long PR, not this long, but long PR. And so was the pacemaker was not replaced, and the patient was followed. And this is now 15 years later, actually. And we see that the PR is quite long. So at this stage, and I should say that the entire workup of that patient, as usually is the case, was negative, both for mother and the child. And so in this case, we're just monitoring this patient. But with the PR that is this long, I have informed the family that it is my guess that eventually a pacemaker will be necessary. And on Zeo patches, there have been episodes of Mobitz 1 and even a rare possible Mobitz 2 here and there. But there's never been a pause on the monitor for more than 2 or 2.5 seconds, and nor has there ever been more than two P waves that didn't conduct. So, and the patient, I'm not sure that this, in getting a history, he told me that he actually was sleeping 5 hours a night and was on his phone all night and staying up late. So, with teenagers, you always have to be very careful when you get a complaint of being tired. I would be surprised if you could find a single teenager who told you that they were very well rested. That's unusual, obviously. So anyway, very good. A lot of interesting points about differential diagnosis. Okay.
Can I ask a question about this?
Yes.
So, like for like this story that you described for this patient, like how often do you like it seems like he's been very stable, but you as you've discussed with the family, like there's a risk of it progressing and he's shown history of it. It's like my question, I guess, how like frequently do you follow like this patient in particular? Like
Yeah, it's a good
every six
question.
months or
Well, a lot of
or
it depends. This is a good style question. This is ultimately a style.
yeah.
What I would say to you is that some of it is how reliable is the family? And the
Mm-hmm.
other thing is what's been happening from Zio to Zio to Zio. In other words, if I saw this patient 6 months ago and the PR interval was 250 and today it's 420,
Yeah.
feel very differently about when I should see them next time versus if the PR was 390 on the last visit a year ago and is now 405,
Mm-hmm. Yeah.
I will tell you, I have had a handful of patients like this who have progressive first degree heart block. I used to take care of a young lady. She's now in her 30s, I think, and followed her from the time she was diagnosed at like maybe 10 with first degree heart block. Her PR was like 260. And I did a stress test on her and showed that her PR would shorten with exercise and she could conduct one-to-one to like 210 easily. And did many, many ZOs with her. And every year I would see her, her PR would be a little bit longer. And the last visit I saw her in the office, it looked kind of like this patient. The PR was like a little on maybe hers was 380. This one is over 400, but
Mm-hmm.
was very long. And the next thing I knew, about 6 months later, she was in the emergency room after a syncopal episode, and she was in complete heart block, actually.
Mm-hmm.
Um, I don't know what she had. She did have genetic testing also for T-box and other things, which were negative. And so we ended up putting a pacemaker in her, and she's now a successful business person, but um, has a pacemaker. So yeah, I don't know the right answer. I think a lot of it has to depends on the degree of progression, how rapidly it seems to be progressing. I often say when I'm following patients with longitudinal issues, I often will say, you need to have at least 2 points on a curve to make a curve. And so if I see somebody has something that I don't think is normal and is worrisome, I will often see them sooner as a second visit because
Mm-hmm.
I don't know what the progress of that, whatever that is. For example, you see a baby with mild pulmonary stenosis. You don't know if in a 2-week old, if in 6 months that mild PS is going to be a gradient of 100 or a gradient of 23. And so,
Right.
and then of course, this is why you need to know the natural history of things, because that will help inform how quickly or often you should see patients. Because this is idiopathic and we don't really know, initially I would follow a patient like this more frequently. And then as I became more comfortable that the rate of progression wasn't very fast, I might see the patient slower. I mean, I worried that I'm going to get the same phone call that she has, that he has fainted. But I can't justify putting a pacemaker in somebody who has like one or two non-conductive P waves on a Zeo patch. It just seems, and this
Mhm.
tiredness. Now you could argue if you look in the official recommendations, it is a 2B recommendation if you have first degree heart block and are symptomatic. But that is very, very unusual, and I've never seen that. And this tiredness and weakness complaint, absolutely, I don't know. You would have to really prove it to me that it had anything to do with this conduction.
Mhm.
Patient has never had syncope, by the way, or that would be a worrisome finding, obviously. So I saw this patient not long ago, and so I'm interested to see what their Zeopat shows. But it's usually, you know, not normal, but not enough to do anything about it
Mhm.
just yet. Again, you might ask the question, why would we even allow somebody to go this long? Like, why wait until they faint? Well, again, we've talked about this in the past, but there are major implications of putting transvenous pacemaker in a patient. Somebody who needs lifelong pacing, to use up the central venous system with a lead or two leads is a big deal, because a 15-year-old could potentially have 85 years ahead of them. And in a general sense, we don't usually think that pacemaker transvenous leads are going to last more than about 30 or 40 years. And extracting a lead from a pacemaker that's been in for 30 years, I am not an extractor, but I'm quite sure that if we had one on the line, they would tell you that that is something they would be very frightened of and not happy about. Just to give you an example, a few months ago, one of my patients had three transvenous leads, and one of them was an abandoned lead from when she was 4, and two of them I had placed when she was like 4, and we're now in for about 12 years. The two leads I placed, the extractor pulled out, thankfully without too much difficulty. But they didn't even try to take out the lead that had been put in when she was a very small girl, that had been abandoned in the past, because they expected it was not going to come out, or that it would have been very risky. So whenever, as a pediatric electrophysiologist and as a pediatric cardiologist, we always have to think long and hard about putting pacemakers in. And one of the big debates in the world of cardiomyopathy is the hypertroph and who needs to get a defibrillator. And there are now many refined algorithms, some of which are online. There's the primacy one, which comes out of Toronto, that try to risk stratify these patients. And part of the reason that that has been an important goal is because when we apply adult standards to pediatric patients, you would think that almost all hypertrophic cardiomyopathy children need to have a defibrillator, because a lot of them meet some of these criteria that are standard for adults. And a lot of our adult colleagues look down upon pediatric electrophysiologists for not, quote, protecting their patients. But it's because we're very cognizant of the risks associated with long-term pacing. The incidence of inappropriate shocks, for example, in children is very high. It could be as high as 15% in many series. And so because of that, because of the difficulties with vascular access, we think a lot more, I think, in pediatrics about when patients should get pacemakers. One could argue that if you, on this patient we're looking at here, if you did a Zeo and you were like many, many episodes of Mopitz 1 and maybe even one or two of Mopitz 2, that you would sort of say, oh, well, this patient's having Mopitz 2, we should probably put a pacemaker in. It's not that it would be wrong. It's just that we have to be cognizant of the future of these patients. And so we drag our feet as long as we think we can safely do so in a patient like this. Any other questions about this?
No, thank you.
All right, thanks, Molly. I think we'll stop here. I hope everyone has a great day. I'll see you at sign out, and and talk later. Have a good one. Be well.
Thanks.
Bye, everyone.